I need to tell you something that has been weighing on me for years. Something that might end my friendship with a few surgeons. But I do not care anymore because what I am about to share could save your life or the life of someone you love. I am a doctor. I have spent 30 years in internal medicine working alongside surgeons, consulting on their cases, and watching what happens to my patients after they come out of the operating room. And I am about to tell you about 5 surgeries, 5 common procedures that hospitals perform on seniors every single day that I would absolutely never under any circumstances. My mother is 76 years old, allow my own mother to have. Not because these surgeries do not work. They do. The problem is what comes after, and nobody is telling you the truth about it. My mother is 76 years old. She is sharp. She is independent. She still cooks Sunday dinner for the whole family. Last year, an orthopedic surgeon looked at her knee x-rays and said she needed a total knee replacement. He said it casually, like he was recommending a new pair of shoes. I sat in that office and felt my blood pressure rise because I knew something that surgeon either did not know or did not care to explain. What I'm going to share with you today is what I told my mother that night at her kitchen table, It is what changed her mind, and it might change yours. But I am not going to tell you those 5 surgeries just yet. I know that is frustrating. But if I just gave you a list, you would miss the critical context that could mean the difference between keeping your independence and losing it forever. You need to understand what actually happens inside a senior's body during and after surgery, what the research shows, and what we doctors discuss among ourselves but rarely share with patients. Let me tell you about Margaret. She was 74 years old, a retired school teacher who volunteered at her church every Wednesday and walked 2 miles every morning with her neighbor. Last September, Margaret slipped on a wet floor in her bathroom and fractured her hip. It was not a terrible fall. She called her daughter herself. She was calm. She was admitted to one of the best hospitals in our city within 2 hours. Everything looked perfect on paper. Margaret's heart was strong. Her kidneys were functioning well. Her blood work was better than most 60-year-olds I see. The orthopedic surgeon was excellent. The surgery itself was textbook, 2 hours, no complications, hardware placed perfectly. When Margaret woke up in recovery, she smiled at her daughter and asked for a glass of water. The surgery was a complete success. But here is where the story takes a turn that I see over and over again. On day 3 after surgery, Margaret's daughter noticed something wrong. Her mother seemed confused about what day it was. She asked the same question 4 times in 10 minutes. The nurses said it was normal. Post-operative confusion. Nothing to worry about. By day 5, Margaret did not recognize her own daughter. She became agitated. She tried to pull out her IV line. She was convinced she was late for a class she had retired from 12 years earlier. This is called post-operative delirium, and it is devastating. The medical team treated the delirium, but Margaret developed pneumonia because she was not moving enough. The pneumonia required stronger antibiotics. The antibiotics destroyed her gut bacteria and caused severe digestive problems. She lost 18 lbs in 2 weeks. Physical therapy became impossible because she was too weak and too confused. What was supposed to be a 5-day hospital stay turned into 6 weeks. When Margaret was finally discharged, she did not go home. She went to a nursing facility. 8 months later, Margaret is still there. The hip healed perfectly. The hardware is fine. The surgery was a technical success. But Margaret never returned home. She lost her independence. She lost her confidence. And according to her daughter, she lost something essential about who she was. The surgery worked, but Margaret's life was destroyed. I need you to hear me when I say this. Margaret's outcome is not rare. This is not an exception. This is a pattern I have watched unfold hundreds of times in 30 years of practice, and it is time someone talked about it honestly. Now let me explain why this happens because why surgery after 65 is fundamentally different. The science is clear and it should make you angry. Not at doctors, but at a system that is not built for aging. How anesthesia affects older brains' bodies. First, anesthesia affects older brains in fundamentally different ways. A 2023 study published in JAMA Surgery followed over 15,000 patients aged 70 and older who had major surgery. What they found should stop every family in their tracks before signing a consent. The 40% cognitive decline statistic form. 40%, nearly half, experienced measurable cognitive decline after surgery, not temporary confusion that clears in a few days. Actual cognitive function decline that persisted 6 months later. The anesthetic drugs accumulate differently in older brains. They interact with medications seniors are already taking. They disrupt neurotransmitter systems that are already fragile from decades of use. Every hour under general anesthesia. Every hour under anesthesia. After 65. After age 70 increases the risk of permanent cognitive problems. I have stood at bedsides watching patients who went in sharp and came out unable to remember their grandchildren's names. That is not a complication listed on the consent form. Second, the hospital environment itself is toxic to elderly patients. Think about what a hospital actually is. Fluorescent lights blazing 24 hours a day, machines beeping constantly, strangers waking you every 2 hours to check vitals, unfamiliar bed, unfamiliar sounds, complete destruction of your sleep cycle. For a 40-year-old, this is annoying. For a person over 70, it triggers a catastrophic cascade. Your internal clock gets destroyed. You cannot tell day from night. Disorientation becomes delirium. Delirium requires sedatives. Sedatives cause more confusion. The cycle spirals downward and sometimes it never comes back up. Third, immobility after surgery destroys elderly bodies at a speed that shocks even me after 30 years. Research from the Journal of the American Geriatric Society measured muscle loss in hospitalized seniors. They lose between 1 and 5% of their total muscle mass every single day they are bedridden. Every day a 45-year-old loses maybe 0.5% and rebuilds it in weeks. But a 75-year-old losing 3% daily for 2 weeks has lost nearly half their muscle strength. That muscle does not come back easily at that age. You are not just recovering from surgery. You are recovering from the catastrophic physical collapse of recovery. Physical collapse caused by the recovery itself. Fourth, elderly patients experience what we call the cascade effect. One complication triggers 3 more. Surgery leads to delirium. Delirium leads to immobility. Immobility leads to pneumonia. Pneumonia requires antibiotics. Antibiotics destroy gut bacteria. Gut problems cause malnutrition. Malnutrition impairs wound healing. Poor healing causes infection. Infection requires more surgery. I have watched patients come in for a routine procedure and leave 3 months later having survived sepsis, pressure ulcers, hospital-acquired infections, and deep vein thrombosis, none of which were complications of the original surgery, all of which were triggered by it. And fifth, the body's recovery capacity after 65 is fundamentally different. This is not about being old or weak. This is biology. Your mitochondria do not produce energy the same way. Your immune system does not respond to stress the same way. Your hormonal environment does not support healing the same way. A 50-year-old body sees surgery as a challenge to overcome. A 75-year-old body sees surgery as a life-threatening crisis and responds by going into conservation mode. Sometimes it never comes out of that mode. Let me tell you about Robert. He was 69, a retired firefighter who still ran 3 miles every morning. He developed appendicitis. Straightforward emergency. The surgery took 45 minutes, no complications. But Robert's recovery took 4 months. He lost 30 lb. He developed such severe fatigue he could not walk to his mailbox. A year later, he still had not regained his strength. He told me that surgery aged me 10 years in 10 days. Or Susan. She was 74 when she developed severe diverticulitis. Her surgeon recommended removing part of the diseased colon. The surgery went fine initially, but she developed sepsis 4 days later, then an abscess that required emergency surgery. Then the wound would not heal. Over 8 months, Susan had 4 major operations. She died of complications from the 4th one. Now you are ready. Let me. The 5 surgeries I'd never let my mother have. Tell you the 5 surgeries I would never let my mother have. And, more importantly, what to do instead. Number 1. Hip replacement surgery after age 1. Hip replacement surgery after 75. Before orthopedic surgeons send me angry messages, let me be specific. I am not saying hip surgery is never appropriate. I am saying the risk calculation changes dramatically after 75. A study from the British Medical Journal tracked 8,000 hip surgery patients over 75. Within 1 year, 28% had not returned to their previous level of function. 15% were in nursing homes. The surgery has a 95% technical success rate, but the life impact success rate is much lower. The alternatives include intensive physical therapy, pain management protocols, mobility aids, home modifications, and sometimes accepting reduced mobility with an adapted lifestyle rather than risking catastrophic decline. Number 2. Emergency colectomy for diverticulitis. Emergency colectomy for diverticulitis, or bowel obstruction. The mortality rate for emergency colon surgery in patients over 70 is between 15 and 25% depending on the study. For survivors, the recovery is brutal. Temporary or permanent colostomy bags, chronic digestive issues, months of recovery. The alternative is aggressive medical management first. Antibiotics, bowel rest, drainage of abscesses. Many situations that feel like emergencies can actually be managed conservatively. 3. Perforated ulcer repair in frail patients with the right specialist. Number 3. Perforated ulcer repair in frail patients. Patients over 75 with perforated ulcers who undergo surgery have mortality rates between 30 and 50%. The surgery is high risk. The recovery is devastating. In select cases, some specialized centers are having success with conservative management, aggressive antibiotics, drainage procedures, intensive monitoring. It does not work for everyone, but it is worth discussing before jumping to major surgery. Number 4. Anctomy for bowel obstruction. 4. Enterectomy for bowel obstruction. This surgery involves removing diseased sections of small intestine. The technical success rate is good, but the functional outcome for seniors is often poor. Prolonged recovery, nutritional complications, high risk of needing additional surgeries. Many bowel obstructions can be managed with bowel rest, nasogastric decompression, and careful monitoring. Push for conservative management first, unless there is clear evidence of dead bowel. 5. Appendectomy in patients over 80. Number 5. Appendectomy in patients over 80. The mortality rate jumps from less than 1% in younger patients to 5 to 8% in patients over 80. Here is what most people do not know. A 2023 Scandinavian study showed that about 70% of uncomplicated appendicitis cases in elderly patients resolved with antibiotics alone. No surgery needed. This is controversial and it does not work if there is perforation. But the option exists and you deserve to know about it. Now, which of these 5 has affected you or someone you love? Drop it in the comments. I read every single one. Here is your 7-step action. Your 7-step action protocol. Print this out. Protocol. Print this out. Bring it to every doctor appointment. It could save your life. Step 1. Before any major surgery, ask your surgeon to calculate your frailty index score. This is a validated tool that predicts surgical risk in elderly patients. Takes 5 minutes. If your surgeon does not know what it is, that is a red flag. Step 2. Request cognitive baseline testing before surgery. Simple memory and attention tests before anesthesia, then repeat them 6 weeks and 3 months after. If cognitive decline happens, it is documented. Step 3. For any recommended surgery, specifically ask what are the non-surgical alternatives and why are we ruling them out. Make the surgeon explain why conservative management will not work. Step 4. Get a second opinion from a geriatrician, not another surgeon. A geriatrician who specializes in managing elderly patients without surgery. Ask them what they would truly recommend if it were their own parent. Step 5. Ask about the POSSUM score. This is a surgical risk calculator for elderly patients that gives you a percentage chance of complications and mortality. Step 6. Create an advance directive with specific language about quality of life priorities. Statements like, If surgery would likely result in permanent nursing home placement, I decline surgery in favor of comfort care. Step 7. Insist on a family meeting with the surgical team where you explicitly discuss worst-case scenarios. Ask what percentage of patients my age end up in a nursing home after this surgery. What percentage develop cognitive decline? What does the worst case actually look like? Let me bring this full circle. Last year, my mother's orthopedic. My mother's story. What we chose instead of surgery. Surgeon recommended knee replacement surgery. We sat at her kitchen table and went through everything I have just told you. We calculated her frailty index. We discussed her priorities. She wanted to keep cooking Sunday dinners. She wanted to keep going to church. She wanted to keep being herself. We got a second opinion from a geriatric rehabilitation specialist. That doctor recommended an aggressive program of physical therapy, joint injections, and lifestyle modifications instead of surgery. My mother chose that path. It has been 14 months. She still has the bad knee. The X-ray looks the same, but her pain is manageable. She is still cooking every Sunday. She is still going to church. She is still herself. Would surgery have given her less pain? Maybe. But at what cost? She made an informed choice based on her values, not just on what the first surgeon recommended. That is what I want for you. Now, I want to be honest with you for a moment. Not as a content creator, as a doctor, and as a son. I have watched families destroyed by surgeries that should never have happened. I have held the hands of patients who told me they wish they had never agreed to the operation. I have read the charts of people who walked into a hospital independently and never walked out again. And in case after case, the family told me the same thing. Nobody explained what could really happen. Nobody told us there were other options. You now have the information. The question is what you do with it. Share this video with someone you love who is over 65. Share it with their children. Share it with anyone who might be facing one of these decisions. It might be the most important thing you do for them this year. Hit that subscribe for more senior health content subscribe button so you never miss a video. I am Dr. James Harrove, and I will see you in the next one.